oriented partnerships. We aspire to empower the continent to ultimately address health security challenges. We work through grassroots community healthcare, incorporating digital technology for greater connectivity, strengthening essential capacities for self-sufficiency, fostering collaboration with all stakeholders, and addressing climate change threats to ensure disaster readiness in the face of environmental shifts. This holistic and inclusive approach is aimed at protecting, enhancing, and saving the lives of every single African. Over the next 3 days, we will hear how we can ramp up research, forge new partnerships, and map out strategies to redefine Africa's place in the global health landscape. Thank you for joining us at CPHIA 2023. Together, we will build a better, healthier, and more secure future
I hope you guys know that on the Zoom there is no audio.
and the world.
On the Zoom there is no audio. I hope you guys are aware.
Welcome, everyone. His Excellencies, Honorable delegates and ladies and gentlemen, all protocols being observed. Welcome to this session on the pandemic preparedness and resilient financing mechanism for Africa. So it's an honor for me to moderate this session. Every stage, the leaders who inspire us in the continent with the work that they've done in the field of public health. So let me give you an overview of this session. Africa continues to face outbreaks of high consequence infectious diseases like Ebola, Lassa fever, chikungunya, COVID-19, and most recently Marburg. As these threats persist and grow, it's urgent to prevent and control future outbreaks. With a particular on developing sustainable financing models to create more resilient public health preparedness infrastructure. This session will explore a combination of strength, disease surveillance systems, and more resilient structures that improve Africa's capacity to detect and mitigate of infectious diseases. With lessons from COVID-19 and other outbreaks, this session will also focus on the importance of quick response effort, with an emphasis on securing and maintaining funding and strong healthcare systems to better handle serious infectious disease outbreak and minimize the impact. So all the presentation that you see during this morning will cover the following objectives: review laboratory, manufacturing, and risk mitigation capacities across the continent and identify gaps and synergies. Describe recent advances and challenges in the laboratory, manufacturing, and risk diagnostic of high-consequence infectious diseases, including the implementation thereof in Africa, to promote one health approach for the preparedness to disease outbreak on the continent, and to review the regional financing mechanism for pandemic preparedness and response to disease outbreak. Ladies and gentlemen, let me introduce the first speaker, Honorable Sabine Nsanzimana, the Minister of Rwanda, to give his remarks.
Morning, bonjour. Director General, Africa CDC, Dr. Jean, Regional Director, WHO Africa, Dr. Moeti, our co-chair, 2023 CPHIA, honorable ministers, delegates, ladies and gentlemen. It's a pleasure to be here this morning to discuss this important topic, pandemic preparedness and response, and how we finance it. I'm sure most of the people in the room know exactly what we should do. And what has to be discussed more is how fast can we do what we know that we should be doing. And I want to share a few experiences from my role as one of the actors in pandemic response on the continent, but also I will talk about the financing in my other capacity for pandemic fund, where I serve as co-chair. First of all, it should be as simple as how do we start by knowing the problem? How do we confirm the problem? And how do we respond to that? How do we sustain? And how do we build the systems? And that has been simplified in many documents and strategies. I think Africa CDC has done a great job. WHO in many countries, we have already strategies for pandemic preparedness response. And where I've been missing the points in many cases is how early do we know from a case to an outbreak? How do we stop it to become a pandemic that affects many places? And it all starts with the early detection, the report, the sample collection, to the lab. How do we supply our laboratories so that there's no interruptions to diagnostics? How do we know the next variants before it become another source of new outbreaks? And also, how do we develop treatments and even vaccines to stop the spread of outbreaks or pandemics? And then the issue of funding comes as another point, that how do we sustain this? I think post-COVID has shown us that we have all we need here at home, in our countries, in our programs. What we need more is how do we work together to strengthen our laboratories, strengthen our teams, our epidemiologists, our field epidemiologists, our response teams, our detection capacities, and how do we collaborate with real-time data sharing, that what is known in Lusaka is known in Cairo, in Kigali, in Brazzaville, in other parts of Africa and beyond, because these pathogens do not respect any border, but they can spread quickly within 10 hours in all continents. With modernization, it travels, it's easier for diseases, it's easier for people as well. And sometimes we need to take this opportunity to stop this spread by knowing better, being faster than diseases. With technology we have, with lab capacity we have, with diagnostics, with artificial intelligence and many other tools, we can do better. Now, how much does it cost us? Again, this is another discussion. I think the faster we do it, the cheaper we're going to spend on these programs. And that should be the discussions to see the frameworks we build with the Global Fund, with PEPFAR, with the World Bank, with others, should be a basis not only to fund diseases, vertical programs, but also to fund systems that for any outbreaks can be viral today, can be bacteria, can be catastrophic, climate change related disruptions, can be flooding, can be cholera. So it can be anything. And that's why understanding that funding our systems is not funding a virus or funding a vertical system or programs, or even a country, should be across systems that when we have a shock pressure, it helps us. And we've seen it. We've seen what we did in the HIV preparedness, in HIV response. The lab we built, the people we trained, were the same people in the last 3 years have been at the forefront of COVID-19 response. So moving forward, all these funding mechanisms, Global Fund I mentioned, PEF I mentioned, and the Pandemic Fund that is probably one of the youngest, like co-chair with Dr. Basri, we are also looking at the same way. How do we make sure this fund is not duplicating, overlapping, or vertical to any programs? It builds systems, builds surveillance, diagnostics, trains people, it helps countries, and it goes where the most need is. And we see the highest burden of diseases, it's here on this continent, and more capacity to build is here. And we have also solutions we can build south to south to take to the north, from the north to the south. And the end, we have a better prepared world. So without taking much of your time, I want just to highlight that what we need to put in place, we already know. And there are 3 things, probably 4 things we need to connect to move forward. Number 1 is leadership. It has been emphasized yesterday, as Excellency the President of Zambia. Leadership drives everything. Leadership needs science, needs evidence, needs facts, so that you make right decisions. You need also the community to be part of the solutions. Otherwise, leadership and science alone cannot solve community problems. And last, you need communications and media so that people now, what we say here, gets everywhere across the world. So I would like to conclude my few remarks on these 4 points, reflections, that the more we connect this, the more we are prepared, and the more even funding will flow to where we have to act. Thank you so much.
Thank you, Dr. Sabine Nsanzimana, the Minister of Health of Rwanda. The next presenter is Dr. Marawi, Head of Surveillance and Disease Intelligence Africa CDC. Dr. Marawi will talk about preparedness of future high-consequence infectious disease outbreaks in Africa, utilizing the One Health approach. Dr. Marawi, the floor is yours.
All right, thank you, Mr. Moderator. Good morning. I will stand on the protocols already set. My presentation is really pretty simple and fast. I was wondering really that topic is very broad, wide, and how I can put it in 10 minutes and in 3-4 slides. So I'll give you the context we are operating in Africa and the gaps and challenges we have and the initiatives that we took currently. And I will conclude my points with a call to action for all of us. Slide. Slide, please. Yes, next slide. Yes, thank you. The continent Africa is really the most vulnerable for infectious disease and also all other health emergency stressors, including extreme weather events, conflict and displacement, and others. And when it comes to infectious disease, especially high-consequence infectious diseases, over the last 30 years, over 30 new pathogens have been reported across, and of these 75% are animal origin. That is really a huge number. In Africa, we report over 100 health emergencies every year annually. But to be strict, if you see this year, we tracked over 158, as of today, 58 health emergencies across the continent. Of these, 90% are infectious disease outbreaks and 70 are more zoonotic diseases. So if you see this map is from Infectious Disease Vulnerability Index. As you can see, the continent Africa is most vulnerable. And of the global 25 vulnerable countries, 22 are in Africa. And you see all across the sub-Saharan region that you can see when it comes down a little, it is more in a rainforest dense region where there is a huge biodiversity, which is also another area that any potential outbreaks can really emerge. Please have a closer look to it. Our current stressors, including going into the forest and so on, are really another major risk and vulnerability. Next. I think. Yeah, it's this, even though we have a huge such a vulnerability and gaps on infectious disease, when it comes to global health security index, which is pretty much really comprehensive assessment tool, you can see the continent Africa is not yet ready, and overall, no country is really well prepared for the next outbreak, and even Africa is the worst. The global average is around 38.9 out of 100, and Africa is 29.1 out of 100. You see the major gaps. When we dive a little, next slide. I don't think this thing. When we dig down a little and see, look into on the IHR core capacities, this is 3-4 years old, but it is really pretty much still the same with the self-report, the current self-report on IHR core capacities. This is, you can see a number of countries are not yet there. Significant number of countries are really either red, which is capacity not existent, or it is not anymore stable. The deep green is capacity that is sustained, and those green light are demonstrable capacities. So you can see all these rates are areas that we need to act immediately as possible. Knowing this challenge, next slide. Knowing these challenges and learning from the pandemic, African CDC and WHO has took different initiatives to bridge these gaps. As you can see, it strengthening the overall health system is one health approach, and capacity development. We launched different initiatives, including workforce for emergency. We call it AVOC Serve initiative, and EIS and fellowships, different fellowship, and strengthening the NPHIs and PHOCs, African Emergency Operation Centers across the continent, local manufacturing and supply chain with establishment of regional hubs at different locations across the continent, and development and cross-border collaboration framework. When pathogen prioritization and ranking has been done to strengthen and identify those gaps and challenges. Moving forward on the coordination and collaboration and cooperation across here in Africa CDC, WHO, and Africa CDC has developed a joint emergency action plan, which is really pretty a game changer that we identified as the priority areas of action for the continent. And we have also initiated a regional integrated surveillance and laboratory network, which brings assets across borders so that they can prepare better and respond faster. And we have pathogen genomics framework networks across the board. This is really another objective, and this is some of those initiatives. When environment, like policy, plans, procedures, and financing. We have initiated to review existing protocols and procedures to fit for purpose, and long-term procurement agreements with different medical countermeasure suppliers, and financing the response, especially Africa Epidemic Fund, and innovative financing, which is a flagship for the Africa CDC Director General, and also another risk financing mechanism, which is initiated by Africa Risk Capacity. These are really some of those big initiatives to bridge the gaps. Next. Yeah. However, these efforts are not yet enough. We need really to act together. One, I'm here to ask for call to action. It is financial investment in preparedness. Investing $1, according to return on investment, is $8.3. And according to the report from the One Health Corporations, 3.7 billion US dollars needed for for better preparedness, which is really ultimately saves around 30 billion US dollars. This is really significant. And support, collaborate, and strengthen the critical initiatives and efforts, especially learning from the pandemic, and we need to sustain this pandemic innovatives and capacities. Some of those initiatives should be really sustained and continued. And support member states in planning, resourcing, and exercising emergency preparedness plans for high-impact pathogens, high-consequence infectious diseases, and set a peer review and accountability mechanism across sectors and at all levels. I think we said one health, but we need really to come together and have a checkpoint where Ministry of Environment, Agriculture, and others come together and have a thorough peer review mechanism. And I think we need to come together on, and I call in here to improve coordination to maximize impacts. So that is all. Thank you very much.
Thank you, Dr. Mary, for this nice presentation. So I'm going to introduce the next presenters. I have the honor to have His Excellency Dr. Jean Casea, the Director General of Africa CDC, and Dr. Matshidiso Moeti, the Regional Director of WHO Afro. Please come on stage. Yeah. So we can start with Dr. Moeti for your short remarks.
Okay. Thank you very much. Dr. Jean Casea, the DG of Africa CDC, Honorable Minister Sabin, leading many things happening at the global level at the moment. Thank you for representing Africa really well in some of these mechanisms. Distinguished guests, honorable ministers, esteemed delegates and friends, and most importantly, advocates for public health progress to build resilient health systems. Thank you for having joined us for this session this morning. And your presence at this gathering marks, we think, in WHO for a pivotal moment, a critical juncture where we unite to chart the course forward in addressing Africa's health needs. And thank you, Dr. Marawi, for having summarized the situation really well. So we're standing at the pinnacle of numerous interconnected challenges, and some of them have just been highlighted. And we think that your voice, your participation, and your support become the beacon guiding us towards impactful and decisive next steps. Our collective journey to shield the African continent against recurrent disease outbreaks stands at a crossroads where we must carefully map out our next move. And this session is a big part of that process. It's already been said that annually, over 100 disease outbreaks inflict death and illness on communities, causing soaring rates of morbidity and mortality and socioeconomic disruptions. And our continent really is an outlier as far as that is concerned. This map that was showed illustrates that extremely well. This is compounded by the adverse effects of climate fluctuations and escalated conflicts. These crises then further strain our health systems and threaten effective responses. So in our widespread efforts to protect populations against crises and the accelerating frequency of public health emergencies, one resounding truth emerges: our strength lies in unified action. That's why we're here this morning. I'm really happy to say that we're not starting from scratch. We are seeing an improvement since the West Africa Ebola outbreak in terms of the performance of our systems. We therefore have measured how long it takes now for countries to close down a disease outbreak. And we really have seen a difference since we had more structured ways of looking at this, more resources being invested. And this has happened since the Ebola outbreak in West Africa. We acknowledge, however, that we still do have a long way to go. And this discussion we're having here is an important milestone in that process. So we launched on the sidelines of the World Health Assembly earlier this year, the joint Africa CDC and WHO Emergency Action Plan, or JEEP. And that plan embodies the vision of a One Africa for Health Security plan. We consider that this is a pioneering 5-year strategic partnership and that it will boost emergency preparedness and response efforts throughout Africa and thus ensure that disease outbreaks are managed efficiently and quickly. As I said, we're building on an already existing close collaboration, which was really reinforced during our joint support to our countries during the COVID-19 pandemic, but we already had been working together before. The slide that you saw there, which shows the status of African countries in terms of preparedness, in fact, was a publication from one of our staff, Dr. Talisuna. So it embodies the work that we have done in WHO Afro in terms of assessing the status of international health regulations preparedness of our member states. And that is work that we are progressively doing together. So the JEEP, our joint plan, aims to enhance the continent's capacity to detect, to monitor, and to respond swiftly to health emergencies across multiple thematic areas, including very much local manufacturing, which is a key and priority theme for our future, and digitalization technology to the degree that's possible. So we consider that this is a forward-thinking 5-year strategic partnership led by WHO and the Africa CDC, and that it combines our knowledge, our technical capacity, and funding, as already said by Minister Sabine, to better the lives of people and communities on our continent. In its journey, we'll ensure that the JEEP remains focused on building better health systems, and we consider that this is critical because the detection of outbreaks doesn't happen in a genomic sequencing laboratory first. It happens in a clinic, sometimes in a very far away village away from the capital city. So our investment is important at all levels of our health systems and across different health sectors in order to be really better prepared. As climate disasters, conflict, and the rapid spread of disease threaten Africa's health security, the importance of unity and collaboration can't be overstated. We've experienced that Africa has often been the last to have access to the tools that are needed, to the health commodities, the diagnostics, the therapeutics, and vaccines. And this was really dramatically illustrated during the COVID-19 pandemic. Insufficient investments in health over the years have left African countries dependent on international support and suffering inequitable access to health commodities, as I've said before. And as the world builds back from COVID-19, our leaders have declared that Africa must set itself up to become self-reliant and shape our own unique health future. And I'm very glad that this is not only reflected in statements, but we're seeing concrete action to go in that direction, to organize together the manufacturing capacity, to initiate some actions to start manufacturing some of the tools, and to be talking to our partners about how this is going to be financed as a partnership. So this inspires us as African health leaders that this is not only our agenda in health, but our political leaders have very much taken it on board and are taking action together on this. One path that we need to follow is to foster regional cooperation, such as the GEEP, to consolidate the buying power of the continent and to effectively leverage the response systems across borders on the continent. If African countries come together and commit to a unified approach, we can overturn the fragmented efforts that have long stood in the way of holistic progress on the continent as well as globally. The reality is that we have pressing concerns that remain. We still find ourselves reliant on international funding for emergency preparedness. And this is correct because emergency preparedness is a shared global responsibility. I think Minister Sabine very illustrated eloquently the fact that we can get people flying from one country and one continent to the other. So this really is a collective global concern. What interests us is as the African continent should, within this global process, be truly united and negotiating jointly so that the interests of our continent are met in international and global decisions and agreements that are made. And the GEEP is one way in which we are going to be collecting data and facilitating this collective approach on the continent. Stronger coordination among our nations is going to overcome the significant hurdles that still cause countries to operate under multiple guidelines, resulting sometimes in redundant efforts and inefficiency in our investment in being better prepared. So we really will find that working together across countries and between our two organizations will make the most efficient use of the resources that our nations will invest and that we will obtain from the international community. So better coordination is going to improve how we share vital knowledge and resources among nations, despite clear cross-border and have a clear impact on cross-border outbreaks, for example. Establishing a continental approach will bring several advantages to our emergency preparedness and response systems in the region. And our ambition is to radically improve the efficiency of emergency preparedness and response activities to better control the spread, for example, of cross-border pandemics and outbreaks, and to enable countries to allocate resources to support their affected neighbors in times of need. Through the Joint Emergency Action Plan, we can truly elevate the continent's capacity to respond to health emergencies with unparalleled efficiency, we believe, and effectiveness, anchored in a resolute commitment to leave no one behind. So no village, no person, no district, and no country, as we work together as a continent. At this crucial moment, we need everyone at the local level, at the sub-regional level, at the regional level, at the continental level, and the global actors to work together like we've never done before. By joining forces, we can strengthen emergency response and protect our most vulnerable communities from the harsh impacts of health emergencies. I'd like to also emphasize the fact that not only are we supporting communities, but we need to engage them and we need to empower them, because without their active engagement, without their gaining the knowledge, we will not be able to succeed, even if we put together important and really brilliant plans at the capital level. So speaking to people, communication, I can only echo what Dr. Sabine said, is what we need to do, because it's at the level of individual people that we're going to have the most impact. So as we venture, while we're here, into conference rooms and halls, let's be united in our quest for resilience, for paving a path that guarantees a healthier and safer future for every person, regardless of who they are, of where they are from, and what they can afford. So I look forward very much, Jean and your team, to our working closely together, to building on our existing partnership, to building on the partnership that exists also among our member states. And I believe firmly that together we can make a huge difference as we embark on this exciting plan. Thank you very much for giving me the opportunity to speak.
Thank you very much, Dr. Moiti. His Excellency, Dr. Jean Kassia, please.
Good morning, everyone. Let me first recognize Dr. Moiti, the regional director, my sister, Dr. Moiti. I think for the past 3-4 days, we are meeting almost every day, and we'll continue. Even I was told that we have some meetings to. Let me recognize Dr. Sabine. He's not only the Minister of Rwanda, but is the chairperson of the Pandemic Fund. He has this huge responsibility to ensure that Africa is held to the pandemic board. And my brother Sabine and myself, we are talking about it. I'll come back to that. Let me recognize our co-chair. Yes, we are missing Professor Senait, this another co-chair, but you are representing Senait here. And I think it's so important to have both of you supporting CPHIA. We have a number of partners and colleagues who are here today. When you are a leader, you can pretend that you know everything, but this is not true. We are here today, 3 people with their team worked for more than 1 year to put everything together. I want to ask Merawi, Dr. Salam, Rick is not here today. Please stand up. We have to recognize you today. Salam is from WHO ASCO, Merawi is from Africa CDC, and Rick Grenal is from EMCO. These are the 3 people, their teams, who had to work on the Joint Emergency Action Plan that we launched together, my sister, myself, and the MRO, the former MRO regional director, with the support from someone who's not here today. I didn't see him, but I met him, my brother Chikwe. We launched that during the WHA in Geneva. Why are we here today? One number, 158 health emergency event since January 2023. Because when we are talking about more than 100 events, we don't know what it means exactly. But I'm telling you, before the end of November, 158. And every day, I have a report. Every day, this report is showing me how the station is becoming worse and worse. About 158 event. We cannot forget that our countries are just going out of huge COVID pandemic. It means our economies were affected. It means our capacity to respond to outbreaks were affected. In addition to that, you need to continue to provide support and to respond to other public health events. We are here also because there is a team. That team was thinking that by putting Africa CDC and WHO, EMRO, and AFRO together, it will help the continental agenda. I didn't see Valerie. I didn't see the GATE team, but I wanted to recognize them. I don't know if someone from GATE is here, but GATE Foundation, someone is here from GATE? Ah, thank you. GATE Foundation decided to put all of us together and to support this vision. Today, we are moving. But I said to my sister Moiti, responding to outbreaks, preparing outbreaks in Africa, it's not just about WHO and Africa CDC. It's about all other partners who are involved. This is why we decided. And I want to thank UNICEF to involve UNICEF to GIP. I see some UNICEF representatives here, they are there. And a couple of months, we had a meeting, thank you. We had a meeting in Addis Ababa involving UNICEF and other partners to discuss how we can operationalize the GIP, because I believe that GIP is not a document just for reference. GIP is an action plan that we need to operationalize. How do we think we can operationalize GIP? Dr. Savin was talking about leadership. Yes, we need a strong leadership. Yes, Africa CDC is providing the political leadership. Yes, WHO is supporting that, but we need more than that. As you know, the Africa CDC Governing Board decided to appoint President Ramaphosa as the pandemic preparedness, prevention, and response champion for Africa. It came because President Ramaphosa was the COVID champion in Africa. Under his leadership, first, Africa CDC did a great job. Second, Africa was the only continent with some innovations on the way to deal with COVID. And then we say, why we need to recreate the wheel? Respectfully, I went to meet President Ramaphosa. I said, Africa needs you. You need to say yes, because this is your continent. And he said, yes. And I briefed him. I said, by accepting to become the PPPR champion, that will be approved during the AU summit in February 2024, your first task will be to champion the JIP, the Joint Emergency Action Plan, to give the political leadership that we need to make sure that all meetings where head of state are sitting, you will talk about the Joint Emergency Action Plan, and to ensure that you will continue to sensitize our head of state, not only to implement that, but to provide funding for that. Because I believe on something. I believe that Africa must start to provide funding to their own programs before going to partners. JEEP, as we have to call it, is not a car, it's a Joint Emergency Action Plan. JEEP is a range of strategic actions to be implemented at local, national, regional, and continental levels. JEEP is bringing disease surveillance, laboratory capacity, preparedness and response capabilities, supply chain management, workforce development, including community health workers, digitization of our primary health system, and climate change response. That one will help to have resilient health systems. But what is missing? What is missing is local manufacturing. We cannot fly with the agenda without local manufacturing. As I said yesterday, local manufacturing is the second independence of Africa. How can you prepare? How can you respond if you don't have diagnostics, if you don't have vaccines, if you don't have medicines? Then we decided to complement the JEEP document by a strong local manufacturing approach. We are talking about everything, but we are not talking about additional financing, because we already agree that African countries will contribute. How they will contribute? We have a mechanism we call African Epidemic Fund that was adopted by head of state in February 2022. Every day, I'm making our head of state accountable to contribute to African Epidemic Fund. For now, we are finalizing the framework of operations of African Epidemic Fund that will be approved in February 2024. Then we will open. I don't want to name countries, but let me tell you, I have already 4 heads of state who strongly committed to contribute from the national budget to the African Epidemic Fund. More than that, we need additional funding. Then let me come back to my brother Sabine. The pandemic fund, 5 African countries. While we congratulated these 5, but we said, and you saw the statement from Africa CDC, clearly saying, this is not what we are expecting in Africa. What we are doing as Africa CDC, the first one is to advocate for more funding for pandemic fund. What I will share with you is a public information. We are expecting maybe the second round to be $2 billion. But during the last vote, they approved the second round to be $500 million. Because they don't have. Yes.
His Excellency.
Yes. We are expecting pandemic fund to have at least $10 billion. But with this $500 million, we'll work together with WHO, with Dr. Sabine, and with all to ensure that Africa will get appropriate and at least, even not with the country approach, but with the regional approach that was approved, all African countries will be covered. Thank you. Support, and we believe that by working together, we'll make sure that this agenda of JEEP will be implemented. Thank you very much.
Thank you, Dr. Moretti, and His Excellency, Dr. Jean Kassia. You can take yours. Thank you. So the next presenter is Dr. Pascal Ondor. Director of Science and New Initiatives, SLM. Dr. Pascal Andrea will talk about innovative diagnostic and laboratory approaches in outbreak settings.
Thank you very much, honorable ministers, excellencies, esteemed delegates, all protocol duly observed. Good morning, and thank you for allowing me to share some experience from the African Society of Laboratory Medicine today. A slide, please. Next slide. Next slide. So the task I have today is to speak about innovative diagnostic and laboratory approaches in outbreak settings. And I really thought I wanted to give the perspective of the people on the ground, the ministries of health, the laboratory workers that really have to implement those innovations and work with the funding. So I like to start my presentation always with a definition. So what is an innovation? It is a new idea, product or practice that creates value. And the important word here is value. So you realize that innovation is not only about technology, but it's how sometimes we approach things. So for diagnostic and laboratory during the outbreak, there were a lot of value that has been brought from the pandemic. So some of the concerns were really to have a swift and reliable detection of the pathogen at screening and confirmation, reaching out to the community, because obviously entering in the health system when you live in a village where you are in contact with the infection is not always easy. Handling more patients as more and more cases are coming to the health system, and also maintaining essential diagnostic services while you are also managing an epidemic. And finally, as it has been said this morning, rely on local expertise and existing capacity, because you do not want to build a parallel system. Next slide, please. So here I listed some of the innovation that were brought during the COVID-19 pandemic. And by all means, I couldn't be comprehensive enough. We had the rapid diagnostic, the point-of-care molecular assay, deployable laboratories, mobile laboratories, self-test, pool testing, and really so many of them. But today, next slide, I really want to intentionally focus on the rapid diagnostic test. And why do I do that? Because they are easy. It's an easy innovation, but it doesn't mean that it's easy to scale it up and it's easy to finance the expansion of the rapid diagnostic. Next slide, please. So during the COVID-19, once we scaled up the capacity for PCR, and that was spearheaded by the Africa CDC, played a large role with partners, the WHO, and other partners such as ASLM, the Institut Pasteur Dakar. We had very rapid diagnostic tests for the COVID-19. And we have a rapid diagnostic test for a lot of other pathogens that can cause epidemics, such as cholera, the dengue, Ebola, etc. So that's a very important topic to talk about when we need to scale up and find the funding. So there were early adopters of the rapid diagnostic test. Some countries really didn't even wait for the recommendation of the WHO or Africa CDC. They really moved on with the RDTs because they saw the value. And very quickly, there were thousands of sites in some countries that were conducting the RDTs in those early adopter settings. But then it came with another concerns, because how do you make sure that these tests that are done at community testing are really quality assured? Because they landed in settings where quality management systems were, to say the least, not really very robust in laboratory setting and outside of the laboratory. And there were no, at that time, external quality assessment proficiency panel to make sure that the tests were of quality. And even if they were, it's a challenge to distribute them to so many facilities. So when I talk about community sites, what are we talking about? We talk about borders, point of entries, pharmacies, prisons, the physician's office, really settings where the testing is tricky to conduct. So the innovation that was needed was how can we quality assure rapid diagnostic tests in community testing? Next slide, please. So what we did, learning from HIV, we retooled, or to say a better word is we repurposed a tool, the stepwise performance improvement tool for rapid diagnostic, in other words, the SPI tool, that has been used by the HIV program for many years to assess by observation the HIV rapid diagnostic sites that are doing the screening for HIV diagnostic. And that has been really implemented in many countries. Next slide, please. So what we did was to repurpose the tool and use it for the COVID-19 rapid diagnostic assessment. And in the long term, next slide, it would be the vision to have this tool or such a tool being used to assess the rapid testing of all epidemic-prone disease that are done in the community. Next slide, please. So this has been done by ESLM in collaboration with Africa CDC and with funding from Resolve to Save Life. Next slide. So very quickly, what happens when we go to the sites, the questionnaire is there and we fill it in through an electronic interface and we have a sort of ranking that comes out from the tool. So they are a 5-color coding, and if the site has a color red, that means that they really need to improve all the different aspects that are being assessed. To the green, it's almost like what Dr. Merawi presented for the GE, where the site is really compliant and competent for all the component observed. So you see this picture there, that means we were at a point of entry. You see it's a tent, that's where the COVID-19 was being done, it's raining, and still we managed to use the tool in hundreds of sites during a very short amount of time and under the coordination of the National Public Health Laboratory. Next slide, please. So this is what we obtain. We have dashboards for facilities, and then you have the different component, and you see in red the component where the sites has really to improve. And there are corrective action that can be conducted by the site itself or can be conducted by either the district or the National Public Health Laboratories. Next slide, please. So this is a dashboard that you can obtain per country. We take all the sites and we try to see where is my competence in the different sites here, disaggregated by public, private, or faith-based facilities. And if you have to interpret that dashboard, you could see that the faith-based that have really a better performance, you see more orange and yellow, will be the most amenable readily to conduct those rapid diagnostic tests in a reliable way. So that's a very important decision tool for the public health laboratory. Next slide, please. So in a country, I chose a country to illustrate what happened. So at baseline, 36%, the average quality that we had in those diagnostics rapid testing sites was 36%. But around 9 months after the corrective action were conducted, we ended up to 73%. And what does that mean? That means that more community sites produce reliable COVID-19 rapid testing tests, and there's also some positive effect on the detection because you have better specimen going to the PCR and you can do the confinement also faster. And this improvement was obtained during the pandemic. Next slide. But now, what comes next is what are the resources that we need to scale this up and who has to pay from the country perspective? Next slide. Next slide. So this slide is intentionally very busy, so I'm not going to ask you to read all of it. But when it comes to our experience with country, when we want to consolidate such a system at the level of the Ministry of Health, you need to think about the workforce, the data system, the supply chain. For example, you would need to expand, certify, continue to mobilize the teams, consolidate the coordination capacity of the National Public Health Lab, and that really turns into training, into meetings, into visits on the field. In the data system, you have to think about the servers, the hardware, the software, the statistician, etc. So all sorts of costs that are not coming very clearly at the beginning. We decide to scale up this sort of innovation. Next slide, please. So I would like to end, this is my last slide, with some tricky question. So from the perspective of the country, how is the decision made to invest in scaling up an innovation? So this was a very obvious, straightforward one, but sometimes other innovations that are less obvious can be presented. And it's important that the investments are done really very wisely in a context where resources are very scarce. So where are the funds coming from when we are talking about RDTs? They're coming from the government, maybe the taxpayer money, out of pocket, because the patient is also paying for some of the care and the diagnostic services. So if we implement an innovation, what is the repercussion on the pocket of the patient? There are private donation, private investment. Where do we tap for those private donation? And there's of course international aid, and I think later in the panel there will be colleagues from the Global Fund, that also provide a lot of these international aids. And now really the tricky question, when the funds are there, how are they managed? So is it centralized versus decentralized? Where do they go? Do they go to the Ministry of Health? Do they have to trickle down to the facility in order to scale up the innovation? And are there sufficient funds earmarked for the laboratory services, or are they earmarked only for surveillance? And those funds, are they coming from the routine budget, or do we need to have an extra budget decision in order to scale up an innovation? And are there some financial mechanism that probably my colleague is going to talk about, such as pay for performance, in order to scale up innovation? Thank you very much.
Thank you, Dr. Pascal. The next presenter is Ms. Gwen Mwaba, Director and Global Head Trade Finance at Bank. She talked about the pandemic preparedness and innovative financing mechanism. Please, Ms. Gwen, you have less than 1 minute because we are running late.
Good morning, ladies and gentlemen. I stand on all protocols, and thank you very much for having Bank to share the experience of what we did during the COVID-19 pandemic. So my presentation will take us back so that we can remind ourselves of how Africa stood up for itself when the world left Africa behind, because this sets the tone for how we can then respond as we move forward. Next slide, the clicker's still not working. So many of us will remember the year 2020 very vividly. This is the year when the first COVID-19 virus case first was identified outside of China in the early part of the year. And towards the latter part of the year, it was also the year when the first COVID-19 case was identified in Africa. And during the same year, we also saw the announcement of vaccine manufacturers having successfully completed accelerated trials for access to COVID-19 vaccines. And it became evident very quickly that those countries that had funded the trials and had deep pockets would be the ones that could access these vaccines. And there was nothing heading Africa's way. But at the same time, the COVAX mechanism under the Gavi Alliance was working very hard to try and procure paid for vaccines for low-income countries, mainly in Africa. But these vaccines were not coming, and also their target at the time was scaled up to cover 30% of Africa's population. However, Africa CDC's guidance was that Africa needed to get to 60% vaccination rate for every single country in order for us to achieve herd immunity. So the question then was, where will the other 30% come from? It was at this point in November 2020 that the then chair of the African Union, His Excellency President Cyril Ramaphosa, head of state of South Africa, decided to form the Africa Vaccine Acquisition Task Team. And this task team was given 4 key objectives. The first was to put in place a whole of Africa approach for the procurement of COVID-19 vaccines to ensure equitable access for all African countries. The second objective was to scope the needs from every single African country and also the financing that would be required to pay for those vaccines. The third objective was to source the funding to pay for the vaccines. And of course, the fourth objective was to work with member countries to ensure that collectively as an African continent, we could procure and deliver these vaccines. Next slide. So having set up the task team, it became evident that no single institution on the African continent would achieve these objectives on their own. So President Ramaphosa then appointed a special envoy in the name of Mr. Strive Masiwa to coordinate the activities of the task team. So the first order of business was to set up a special purpose vehicle called the Africa Vaccine Acquisition Trust, which was incorporated in Mauritius. And this would be the entity that would interface with financiers, with vaccine manufacturers in order to ensure that vaccines got to Africa. But there were a number of institutions that were involved in this partnership. One was the United Nations Economic Commission for Africa, which was a technical backstop for the task team, especially when it came to advice on economic dimensions of vaccines and rollouts. And this was also the time when the IMF was making announcements around special drawing rights being available to countries. So the UNECA, using its convening power, was speaking to African governments to ask whether they could set aside some of the proceeds from those special drawing rights to be directed towards procurement of COVID-19 vaccines. Another key partner in this collaboration was Africa CDC. Africa CDC acts as a secretariat for AVAT, but more importantly, was also able to guide countries in ensuring that they had in place their national emergency use authorizations for COVID-19 vaccines once they became available. And Africa CDC were also the clinical advisors to the task team. And then on the financing side, you had Afrexim Bank, which was the institution that was able to get approval of a $2 billion facility, which gave the financial muscle to enable us to be able to stand in front of vaccine manufacturers and negotiate procurement of vaccines. And last but not least, we had a digital platform called the Africa Medical Supply Platform, which basically pulled the demand for the African continent. Next slide. So this slide here just shows you how the financing mechanism works. And I'll just run through very quickly because of time constraints. But basically, the idea here was that suppliers of COVID-19 vaccines did not want to be dealing with 55 separate African countries. So they wanted one interface. So that, which I spoke about earlier, became that interface. So if you can see on the far left of the slide, you have all of the African Union member states. They went onto the African Medical Supplies Platform, inserted their expressions of interest for the type of vaccines that they needed, the quantities that they needed, and when they needed these by. And the digital platform then pulled all of the demand for the African continent. And using that demand on the $2 billion financing facility that Afrexim Bank had put in place, AVAT was then able to start conversations with vaccine manufacturers and say to them, we're not looking for free vaccines. We have the money, we have the demand. Can you please give us a contract and produce vaccines for us? So AVAT spoke to Pfizer, spoke to AstraZeneca, who referred us to Serum Institute in India, who were producing the Covishield vaccine under the AstraZeneca brand. We spoke to Sputnik, we spoke to Sinopharm. Eventually, it was determined that the Johnson & Johnson vaccine was probably the best vaccine for Africa because, number one, Johnson & Johnson were the most forthcoming at the time. And also, it was a single-dose vaccine, which meant that for Africa, which has large rural populations, compliance would be easy. People would come for their one dose, and you don't have to trap people to come back for a second dose. So having secured a contract with Johnson & Johnson initially for a quantity of 220 million doses for the entire African continent, AVAT realized that if we were to scale up and the demand was higher, because the 220 million would only cover an additional 15%, so we needed another 15%. However, the $2 billion was already taken up by the 220 million. So we started to speak to other partners like the World Bank we were approving projects for countries. So as VAT fronted the procurement, the World Bank, when they approved projects for countries, would then assume part of that risk. That was a great collaboration, which is still ongoing even as I speak. And then, of course, on the logistics side, we engaged UNICEF, who is probably the most expert at global procurement and distribution of vaccines. They handled the procurement, the logistics and distribution, and ensured that countries got their vaccines in a timely manner. Other partners started to come into the program in the form of the MasterCard Foundation, who donated $500 million to the program. And what this did is it meant that for every certain quantity of paid for vaccines that a country ordered, they also got free vaccines paid for by MasterCard Foundation and other donors like the MTN Foundation and DIRCO, one of the government departments of the government of South Africa. Next slide. So this slide just gives you the timeline from November 2020 by March 2021, the historic first pooled procurement mechanism contract was signed with Johnson & Johnson. And in August 2021, the first production out of the Johnson & Johnson plant started to arrive on the African continent. Initially, it was a very modest amount of 5.1 million doses, but we actively distributed this to all of the countries that were in the program. And at that point, all the governments were able, and ministries of health were able to breathe a sigh of relief that finally vaccines had started to trickle onto the African continent. Next slide. So as we look forward, this mechanism really demonstrated that if we collaborate and come together as African institutions and partners, we can work with African institutions and global partners to ensure that we source the financing that is required for the African continent. But as Africans, I think we need to move forward first, and then we attract the rest of the investment. So it is quite clear the case for vaccine manufacturing on the African continent has been made. We need to continue to use innovative financing structures and mechanisms to invest in vaccine manufacturing on the African continent. Next slide. There are a couple of ways in which Afreximbank, being an African development finance institution, can help as we look forward. We have a project preparation facility, which is basically a facility that provides upfront funding to project promoters to enable them to conduct their feasibility studies before they set up huge manufacturing plants and facilities. We also offer advisory and trade financing to pay for projects as they come on stream. We also help negotiating and financing intellectual property rights for those who are manufacturing under license. And we also offer country risk guarantees, which are often required by foreign investors when they're investing in continents that they're not very familiar or comfortable with from a risk perspective. And of course, Afreximbank is also instrumental as part of its industrialization program in financing pharmaceutical parks on the African continent for production of other medical supplies and therapeutics. And finally, in terms of the forms of funding, we don't just support debt, we also help raise equity or quasi-equity in order to ensure the success of funding from Africa. Thank you very much, ladies and gentlemen.
Thank you, Ms. Gwen. The next presenter is Ms. Adafai, Chief Financial Officer, Global Fund. She will join us virtually.
Thank you. Thank you very much, sir. Good morning, ladies and gentlemen, heads of delegations and heads of institutions, all protocol observed. I'm Adafai, the Chief Finance Officer of the Global Fund based in Geneva. I am very sorry that I could not be with you in person today, but we at the Global Fund are very grateful to share our perspective on these topics by joining virtually. After listening to all of the speakers, I am reassured by the fact that the work that we do at the Fund remains relevant for the continent and for the people that we serve. We had and continue to have a very active role in funding pandemic preparedness and response, and lessons learned from the COVID-19 to also share that with you. People in this room remember in 2002, the Global Fund has supported and continues to support investments in Africa for over $45 billion. Africa remains the recipient of over 75% of Global Fund funding for the 3 diseases, reducing the combined number of deaths by 41% in the 20 years. These achievements would not have been possible without the efforts of billions. The Global Fund is a partnership and remains a partnership. In my role as CFO, I always say that the reason of being for the Global Fund is Africa. Because if 75% of our funding comes to the continent, we need the continent to achieve our objectives, but the continent also needs the Global Fund to drive the innovation and part of the funding that is needed. So there is need for convergence in the way we drive the individual strategies to serve the people better. We hear a lot around gaps, around challenges in Africa. However, over the last 20 years, the continent has shown incredible knowledge, innovation, commitment, and leadership in fighting the 3 deadliest infectious diseases, as well as responding to COVID-19. Other regions and even continents can take invaluable lessons learned from Africa. Global Fund investment for the 3 diseases have largely contributed to supporting the continent's effort in the systems for health and pandemic. And I'm glad that the Global Fund was mentioned as part of the innovation and work that is going on in laboratories and the diagnostic space. Over 1/3 of our investment in HIV already contribute to strengthening health system and pandemics. Currently about 1.5 billion globally. And when it is coming from the CFO, these numbers are real numbers, and they're numbers that come and serve the people of the continent. In fact, the same labs, supply chain and data systems, and health workers and community systems that benefited from Global Fund investments in HIV and malaria and TB have proven to be strong COVID. We were able to release $500 million of our ALM to support and respond to COVID in Africa. Over the 20 years, fighting diseases, we can say without a good doubt that the best way to prevent and prepare for the future pandemics is by effectively fighting the pandemics of today. We need to act now, and we need to act together. These investments supported eligible Global Fund countries in their COVID-19 response during the pandemic, and we funded several activities in terms of tests, treatment, and then for the first time in the history of the Global Fund, we started to fund oxygen plants, PPE at a larger scale than that we've done before the pandemic peaks to support national responses. As the pandemic started to wane within the finance function and the leadership of the Global Fund, we realized that the $5 billion that we mobilized for the COVID response, 2.2 billion remain available. However, because COVID was waning, we had to shift quickly to support countries, especially Africa, to reprogram and reactivate those funds for the next 2 years. For the period 24 and 25, the Global Fund intends to invest an additional $2.2 billion, and the majority of that funding is going into surveillance, laboratories, diagnostic, human resources for health, and community system strengthening, while scaling up the medical oxygen and other health products and waste management that we currently fund. Let me give you some quick examples of our role in funding pandemics. Integrated text testing, bidirectional testing for HIV, and I remember this was as part of the investment committee of COVID. HIV and COVID-19 has allowed a country like Nigeria to accelerate its identification of people living with HIV, despite the COVID-19 pandemic, and they were able to use some of the same testing machines and kits to help with COVID testing. Labs between 2021 and 2023, at the peak of the pandemic, we have evidence that we've invested $1 billion in lab systems to reinforce both the fight against the 3 diseases and also the response to COVID. Oxygen, I've already mentioned, we've invested a lot in oxygen. And I remember sitting in the room with a tiny bit of conflict of interest, listening to the investment of oxygen plan in my own country, Gambia. Similarly for Malawi and many other countries in the continent. We've learned a lot from COVID, but one of the main lessons is that investing in health is investing in communities and is investing in people. And these investments will pay off to better prevent, prepare, and respond to future pandemics. If we want to see economic growth in Africa, health is one of the ingredients of that growth, and health remains a core element of that drive for economic prosperity. And I'm glad of the conversation today. We've also learned that equitable access, and I'm glad that was the presentation before. Money was available. Accessing the medical countermeasures was not only the fair thing to do, but the smart thing to do. But it was the most challenging during the pandemic. The world had fallen short from that, and we must learn the hard way. Within the fund, we are committed to working with this group of stakeholders and communities to help and drive local manufacturing in Africa. As the Global Fund, we will continue supporting countries in fighting the diseases because that is our core mission. But we also are very concerned about how we work with the continent and other stakeholders to prepare for the next pandemic. But we need your leadership, sustained financial commitment, and the engagement of all partners, private sector, communities, multilateral and bilateral partners. This has to be done in partnership, and the Global Fund is a true partnership model that brings together donors, implementers, governments and civil society, private sector, but also the technical partners, WHO, UNAIDS, Stop TB, and Rollback Malaria. And I think the forces are there for us to join your forces to drive and accelerate what is needed in Africa for a better health for our people. Thank you, and thank you very much. Over to you.
So we invite Dr. Angela Ishaga and Dr. Richard Mingo to conduct the panels.
Thank you, everyone, and thank you for your patience. I'd like to request the panelists to also come up so we can start. As they're coming up, we are running a little bit late behind schedule, but I'm glad that everyone is sitting, feels led by the ancestors to choose a share. And we would love to be able to have each of you respond to at least one question before we bring it to a close. As we've had, resilient health systems are built collaboratively over time, cross-sectorally, centered needs, focusing on all core components of a health system to deliver everyday essential services, and when required, be skilled up to be able to respond and mitigate pandemics. Resilient health financing for these health systems follows similar characteristics: collaborations, community focus, consistency, and catalytic. As Minister Sabine mentioned, leadership drives everything, and I want to thank the panelists for their leadership. And as mentioned by Dr. Jean and Dr. Moati, with more than 100 health emergent events hitting the continent in 2023 alone, it is very important to recognize that resilient health systems and financing needs each of us and all of us. I'm glad to be able to co-moderate this session alongside a friend and colleague, Dr. Richard, from the COVID-19 vaccine delivery, and we're looking forward to being able to bring home some of the points that you raised during your presentations. You were able to delve into a lot of detail, and so we're hoping to ask just one key question that will be able to move us from the call to action to actual action. So I'll start with you, Dr. Pascal. What do you believe are the main barriers to alleviate financing to the scale up and innovation of the diagnosis that you mentioned that are required in the lab strategies?
Yeah, thank you for the question. So I think from the presentation, one of the main consideration would be that the scale up of innovation would need to land as much as possible into existing financial system and financial mechanism so that it's easier. But what we see is that they are really very fragmented in the first place. So I will give an example and really try to advocate for our colleagues, the lab directors in the facilities in the country, the public health laboratories. They do not often have the administrative structure and the mandate to actually receive and manage the funding, or even discuss and convene their counterpart to make a scale up, of an innovation happen. So, and that really ends up sometimes in sort of an absurd situation that even when the funds are available, they are not absorbed by the country and they have to return to the funder because the main stakeholder do not have the capacity or the mandate to actually use those funds. So that would be a number one intervention that I feel very important. And then I think when we talk about innovation, it's not about planting a technology or really try to apply a blueprint. I think that we need to carefully understand, how to contextualize that intervention and to domesticate it and understand, how the money can or cannot flow in the country in a particular setting. And this is really some call that I have to the founders, to people in the bank, to really give time to the country to domesticate this intervention and really do it in the system that is in place in the country. Thank you.
Fantastic. And thank you so much for that, Dr. Pascal. Talking about having the skills and capabilities and at the lab director level to be able to implement the investments that are coming into countries is a very valuable point. Ms. Ada, I hope you're still remotely. You mentioned that the Global Fund is now having much more investment in strengthening existing health systems beyond just the 3 disease focus, which is fantastic. And you gave some examples of what has been done with the C19RM investments. It would be good to hear from you what impact is expected with this widening focus on health system strengthening more broadly.
Can you hear me? Can you hear me? I can't hear you.
Can you hear us now, Ms. Ada? Okay.
Interesting session this morning. I think a very nice presentation from our 4 panelists. Two very inspiring keynotes by Dr. Moeti, Dr. Kasea, I think setting really the stage on what needs to be done in the future. So let me start by my neighbor here, Mrs. Mwaba. You nicely presented how actually Afrexim Bank, and we all recall that period, step in to try to address the gap when it comes to responding to the COVID-19 vaccine. A great deal of lesson that we've learned. Now, I would like to ask you how, with all the experience that has been gathered so far, are you, let's say, preparing to pivot that experience, either to support, and we have heard it loudly, the vaccine manufacturing agenda on the continent? And maybe what else do you think you can do in support, for instance, the health system strengthening, to have a system that is really well prepared to respond to any future pandemic? Over to you.
Thank you very much for that really important question. And you're right. I mean, Afrexim Bank and its partners took a lot of lessons away from our experience having dealt with the COVID-19 vaccine. And the biggest lesson that we took away is that we need to find African solutions for African problems. So even as we look forward to building resilient health systems on the African continent, Afrexim Bank has not stood by and waited. We've already started to evaluate and look at where the gaps might lie, where we can start to intervene. One of the things that we realized very quickly is that Africa spends in excess of $1 billion each year on medical tourism. This is money that is spent by Africans that cannot get specialist medical help on the African continent. So they fly to countries outside of the African continent, to India, to the US, etc. This money needs to stay on the African continent. So we took a step back and said, how can we stem those dollars from flying outside of the continent and retaining them? So one of the first things that we've done is to build a strategy around how we can establish African medical centers of excellence across the African continent, so that we can bring not just the medical facilities onto the continent, but also the medical experts onto the continent. We already of its kind established now in Abuja in Nigeria. There's an African Medical Center of Excellence, and these centers of excellence will deal with non-communicable diseases. So the Abuja facility is a 500-bed hospital. We work in collaboration with King's College Hospital, UK, who are the experts who help with the design of the facility, and also sending their experts to come and give the medical support to Africans here in Africa. So the focus is on things like hematology, etc. And of course, we will continue to roll this out into other African countries. Above that, we also have a financing facility for those investors who wish to construct private hospitals and clinics. We've done one financing of that nature in Uganda. We have a specially designed financing mechanism that enables a construction company to take comfort from the fact that there's a bank standing behind the project promoter, so that they then build the medical facility and the bank takes over the financing once the medical facility is put in place. So this is available to all private investors. In addition, we are already working with a number of see how we can support projects that are going into vaccine manufacturing, and not just COVID, but all vaccines. And Africa, I think, is the largest consumer of childhood vaccines globally. So that's another key focus for Afrexim Bank. So perhaps I'll.
No, thank you very much. Your last comments clearly dear to my and much of my career working on vaccines. Thank you very much. So Africa's solution to African problems, I think this is quite a strong statement. Let me pivot to Merawi. I think we heard a very short but powerful presentation on the JIP, your collaboration with WHO. I think this is really a pivotal moment in public health in Africa that we are seeing. You laid out some different initiatives that you are looking with our colleague from WHO to bridge the gap. And we don't have time maybe to go through all of them. Can we maybe just hear from you? One of them, you talked about health workforce development for emergency preparedness and response, including community health workers. This is a subject that we've heard since yesterday. What exactly, in terms of concrete action, we could expect from Africa CDC and WHO to start moving this agenda forward, and what else other partners can do to support that?
Thank you, Dr. Richard. This is really very important question, and our work served, or health emergency workforce, is one of the big initiatives among the prioritized activities, 8 or 9 prioritized activities in Joint Emergency Action Plan. The essence is we usually call in external parties to come on board and support member states in their outbreak emergencies and responses. But the fact is, emergencies are in the community and in the community, and it is the level all who in that community can really support emergency response. With this philosophy in mind, the WHO Africa CDC joined this initiative. The WHO initiative, SURGE, and Africa CDC AVOC mechanism. We joined them in a way that if we establish a workforce, a health emergency deployable team, trained, equipped, deployable team for member states, at least 50 in each member state, and in some countries it goes up to 150 based on the size of the country. But at least if we have those 50 people who are rapidly deployable within the first 24, 48 hours, that will really make a difference. Even we struggle this period, especially the early phases of emergency outbreak response. So our targets as our search is to have at least 50 in each country, up to 3,000 over the next 5 years. I think we have far gone fast in this track. Closely 1,300 our surge members are already trained in each member states, and we are really moving. The other part, which is like a continental mechanism to deploy team across borders, is another platform that was established following the Ebola outbreak in West Africa. That was like in 2015 that was established by the African heads of state and government to say we need the African Volunteer Health Corps that can be a deployable force during such a crisis, because there was no such mechanism before to deploy civilians in crisis. So this was also now really managed very well in a way that whatever resources we have, we share, we train, we have interoperable and harmonized, well-trained team that can move from border to border to support member states. I think we are moving fast in this. We will achieve it even before the first, in the first 3 years of this. And I think that makes a real difference, because we have a huge emergency workforce gap. Maybe 10% of member states have such an emergency workforce currently. Thank you.
No, thank you very much. Maybe I know we are rushing from time. Angela, if you can give maybe 1 minute to Ada. I don't know now if she can hear us. Back to you.
Yes, Miss Alice.
Thank you very much. Can you hear me? Can you hear me?
Share some of the examples during your presentation. So we do thank you for leaning in and already coming up with presentations. As we wind up this panel, we thank you for your attention. As you've had, pandemic starts and stop in communities. So resilience starts and stops with communities. We need to know that resilient health systems and health financing needs each of us and all of us. We thank you for your attention, and back to you.
Thank you.
Thank you so much, Dr. Angela Tishaga and Dr. Charles Migo. Thank you to all the panelists. So we can wrap up this session. I retain, I think, 4 points. The first one is working together to be ready and better prepared. And working together means to work within the community, the cross country, the regional level, the continental level. The second thing is innovation. So we need to think about innovation. It's not only the blueprint, but it's also the way that we approach things. And the third is funding. So Africa should fund Africa first, and then the continent should negotiate with external funders to prioritize the continent interest. And the last one, this is what His Excellency Kasia said, which is missing in the GP, is manufacturing factories. So we need to promote manufacturing factories within the continent. So thank you so much for all of you for your attention.
Mr. Moderator, I've just been asked by the housekeeping. There is someone who have left his binoculars. You are asked, or she is asked to contact Musa in the interpretation system desk. So for someone who have lost yesterday, his binocular. Thank you.
Our waters, hydrate well for our next session that will last a little bit over 1 hour on transformative leadership for health in Africa. I'll be back in 2 minutes. So sit in your spot and I will be with you shortly. Hi again, everyone. Same Virgie. May I request everyone who's standing and having a conversation to please sit down so we can on time-ish and finish on time-ish. Your Excellencies, Honorable Ministers, Heads of Delegations, distinguished health leaders, esteemed guests, ladies and gentlemen, welcome to this session on transformative leadership for health in Africa. Today, we are honored to host an extraordinary panel of health visionaries, including ministers of health and other leaders who are at the forefront of reshaping the health landscape in Africa. As we heard yesterday, in the opening ceremony, when there is a political commitment from our leaders, anything. Across the continent, we face a great many health challenges, but in the wake of the COVID-19 pandemic, African nations are also demonstrating extraordinary leadership and ingenuity in addressing these long-standing and emerging health. From groundbreaking technologies to cross-sector collaborations, Africans are reaffirming the continent as a powerhouse in science and innovation, a generator of new knowledge and health products, and an exemplar of progress. I invite you now to turn your attention to the screens for a video about the CPHIA 2023 theme, Breaking Barriers. Please watch.
We learned wonderful lessons. First, we cannot deal with our continental each other. The second one, we are just using 100% of vaccines in the executive system. To do this, we are exposed to this. Yeah, we always wait for the answer to the list. Well, that's what we do. I think that is not we have to use the driving signal. We recognize what our challenges and what to do about it. It's to develop the skills of health and the performance and the attitude of cornerstone of the decision making. There's the urgent need of the more just and inclusive approach to global health issues. It needs to be informed by, led by, and has to look like the communities themselves. It's really the utilization of global health. CPHIA is the professor of public health in the school. So the statement, this is the public health but the sufferance just to the scene and the leadership is not going to say long transition that is supporting Africa CDC has been using the recycled product action as an advocacy tool. And so about 26 countries will be supported by Africa CDC to establish functional emergency preparation centers. Africa CDC is applied to the 2020. That's been very massive. CPHIA is working the boundaries for what is historically happening in the continent. It is African-led, it is African design, and it is for Africans. We are using this platform to encourage innovation, to encourage scientific endeavors within the across the continent. Legal manufacturing is the state of independence of us. Legal manufacturing will ensure vaccines, medicines, we are creating jobs, we are creating